She went to the doctor with irregular periods at 17. She was told it was stress. At 24, unexplained weight gain. Told to eat less. At 29, struggling to conceive. Finally, a diagnosis. PCOS. Polycystic Ovary Syndrome. She'd had it for over a decade. Nobody caught it. This video exists so that doesn't happen to you, or someone you love. Section 1. The scale. A crisis hidden in plain sight. Let's start with the numbers, because they tell a story that the medical system has not done enough to communicate. PCOS is the most common endocrine disorder in women of childbearing age, affecting 8 to 12% of reproductive-aged women globally, and is responsible for 50 to 70% of anovulatory infertility cases. In 2021 alone, there were 65.8 million prevalent cases of PCOS globally, and projections from Bayesian modeling suggest that number will rise to 77.87 million by 2036. The global burden of PCOS has escalated by 28% from 1990 to 2021, and the fastest growth is occurring in regions with the least access to care. Adolescents aged 15 to 19 demonstrate the highest incidence rates, meaning this condition is most likely to begin during some of the most vulnerable years of a young woman's life. And here is the number that defines why this video needs to exist. The misconception that PCOS only affects overweight women causes a delay in diagnosis of up to 5 to 10 years. Years in which the condition progresses untreated, symptoms are dismissed, and women are told their pain, their cycles, their bodies are simply normal. They are not normal. They deserve a name, a diagnosis, and a plan. Right now, do you know someone who has struggled with irregular periods, unexplained weight changes, or fertility issues that nobody could explain? Keep them in mind. This might be why. Section 2. What is PCOS? The science behind the diagnosis. The name is misleading, and that matters clinically. Polycystic ovary syndrome implies the primary problem is multiple cysts on the ovaries. But this is not accurate. Those cysts are actually immature follicles, eggs that began developing and then stalled, because the hormonal environment needed to complete ovulation was disrupted. PCOS is a complex endocrine and metabolic disorder, not simply a reproductive one. And understanding what is actually happening in the body is essential to understanding why it affects so many systems simultaneously. Here is the core biochemical cascade. In most women with PCOS, the pituitary gland releases an abnormally high ratio of LH, luteinizing hormone, relative to FSH, follicle-stimulating hormone. This elevated LH drives the ovarian theca cells to produce excess androgens, male sex hormones including testosterone, at levels higher than the female body is designed to manage. These elevated androgens disrupt the normal follicular development cycle, preventing eggs from maturing and being released, causing anovulation, irregular cycles, and the stalled follicle accumulation that shows up on ultrasound. Simultaneously, and this is where PCOS becomes a systemic metabolic condition, metabolic issues like insulin resistance are present in 60 to 80% of women with PCOS. Insulin resistance means the body's cells don't respond normally to insulin, the pancreas compensates by producing more, and that hyperinsulinemia further stimulates androgen production from the ovaries, creating a reinforcing cycle. More insulin right pointing arrow, more androgens right pointing arrow, more disrupted ovulation right pointing arrow, more hormone imbalance. This is why PCOS is not just about periods. It is a condition that intersects endocrinology, metabolism, reproductive medicine, and, as we will see, mental health. Section 3. Symptoms. What it actually feels like. PCOS presents differently in every woman, which is one of the primary reasons it is so frequently missed. There is no single face of PCOS. But here are the most common signals, and what they actually feel like from the inside: irregular or absent periods. Not just a few days late. Cycles that arrive every 40, 60, 90 days, or not at all for months. Many women are told this is normal variation. In the context of PCOS, it is anovulation, the absence of ovulation, and it is clinically significant. Unexplained weight gain and difficulty losing weight. Despite eating well and exercising, weight accumulates, particularly around the abdomen. This is insulin resistance driving preferential fat storage in visceral tissue, not a willpower failure. The body's metabolic environment is working against standard weight loss efforts. Hirsutism, excess hair growth. On the face, chin, chest, abdomen. Caused by elevated androgens. For many women, this is among the most emotionally distressing symptoms, and the one most frequently dismissed as a cosmetic concern rather than a hormonal signal. Acne, especially adult acne. Androgen-driven sebaceous gland overactivity producing persistent cystic acne on the jawline and chin. Distinct from adolescent acne in pattern and resistant to typical topical treatments because the cause is hormonal, not dermatological. Hair thinning on the scalp. Paradoxically, excess androgens cause hair growth where women don't want it, and hair loss where they do. Androgenic alopecia in PCOS can be significant and is frequently misdiagnosed. Mood disturbances. Compared to women without PCOS, those with the condition often experience higher rates of mental health conditions including anxiety, depression, and fatigue. This is not incidental. It is mechanistically driven by insulin resistance, hyperandrogenism, and HPA axis dysregulation. The mind and the metabolism are connected. Pause and ask yourself, how many of these have you or someone you know been experiencing, and brushed off as just hormones? Because just hormones is the answer that has been delaying diagnoses for a decade. Section 4. A real story. The human cost of a missed diagnosis. Consider this story, a composite of experiences shared by thousands of women with PCOS. Aisha was 16 when her periods first became irregular. Her doctor told her it was stress from school. At 21, she developed persistent acne and started gaining weight despite no change in her diet. She was prescribed a stricter diet. At 26, she noticed hair on her chin. She was told it was just genetics. At 29, she and her partner began trying for a baby. After 18 months of nothing, she saw a specialist. Blood work, ultrasound, a 15-minute consultation. PCOS. Why didn't anyone tell me sooner? Because every symptom she presented was treated as a separate, cosmetic, or lifestyle problem, never as pieces of a single hormonal picture. Aisha's story is not unusual. Symptoms typically emerge between the ages of 18 and 39, but diagnosis and treatment are often delayed, leading to many undiagnosed patients. The cost of that delay is not just fertility. It is years of avoidable metabolic progression, untreated insulin resistance accumulating cardiovascular risk, and the quiet psychological toll of a body that never worked the way you were told it should. Section 5. Causes. Why does PCOS happen? PCOS does not have a single identified cause, and this is one of the reasons it remains a syndrome rather than a disease with a defined etiology. What the evidence consistently points to is a convergence of three factors: genetic predisposition. PCOS runs in families. If your mother, sister, or aunt has PCOS, your risk is substantially elevated. Multiple gene variants affecting androgen metabolism, insulin signaling, and LH secretion have been identified, though no single genetic marker explains all cases. Hormonal dysregulation. The LH-FSH imbalance, hyperandrogenism, and disrupted feedback between the ovaries, pituitary, and hypothalamus form the core hormonal architecture of PCOS. What triggers this dysregulation in any individual remains an area of active research. Metabolic environment. Insulin resistance is a very common condition in PCOS, worsened by hyperandrogenism-related adipose tissue accumulation, and is involved in both the pathogenesis and progression of the disease. Critically, and this dismantles one of the most harmful misconceptions about PCOS, lifestyle choices do not cause PCOS. Lifestyle choices cannot cause PCOS, but they can make symptoms worse by doing things that negatively impact insulin resistance. You did not eat your way into PCOS. You did not exercise too little into PCOS. The hormonal architecture was already there. What lifestyle affects is how severely the symptoms manifest, not whether the condition exists. Section 6. Myths versus facts. Myth 1. PCOS only affects overweight women. Fact. Normal weight women can certainly have PCOS. There is actually insulin resistance that is common in PCOS patients, even those of normal weight. Thin women with PCOS are frequently the most underdiagnosed because they don't fit the stereotyped presentation. This misconception delays diagnosis by up to 5 to 10 years. Myth 2. If you have PCOS, you can't get pregnant. Fact. PCOS is responsible for 50 to 70% of anovulatory infertility, but anovulatory infertility is treatable. With appropriate intervention, lifestyle modification, medications including letrozole or clomiphene, and in some cases IVF, many women with PCOS conceive successfully. PCOS is the most common treatable cause of infertility. Myth 3. PCOS goes away after menopause. Fact. PCOS is a lifelong condition associated with metabolic and psychological comorbidities that can impact patients beyond the menopausal transition. After menopause, reproductive symptoms may change, but the metabolic risks including cardiovascular disease and type 2 diabetes persist and require ongoing management. Myth 4. PCOS is just about periods and fertility. Fact. PCOS is a full-body metabolic condition involving insulin resistance, elevated cardiovascular risk, increased likelihood of type 2 diabetes, liver disease, sleep apnea, and, critically, significantly elevated rates of anxiety and depression. Treating it only as a reproductive condition misses the majority of the clinical picture. Myth 5. Losing weight will cure PCOS. Fact. Weight loss can significantly improve symptom severity and metabolic markers in women with PCOS, and is a valid part of management. But it does not cure the condition. Modest weight loss of 2 to 5% of total body weight can help restore ovulatory menstrual periods in some patients, but the underlying hormonal architecture of PCOS remains. Management is lifelong, not a finish line. How many of these myths have you heard from a doctor, a family member, or the internet? Drop the number in the comments. I read every one. Section 7. Treatment. What actually works? There is no cure for PCOS. But there is a substantial, evidence-based toolkit for managing it, and for most women, a combination approach produces meaningful, life-changing results. Lifestyle, the foundation. The Androgen Excess and PCOS Society recommends lifestyle management as the primary therapy for metabolic complications. A decrease of 500 to 1,000 calories daily, along with 150 minutes of exercise per week, can restore ovulation in some patients. Resistance training can improve insulin sensitivity in women with PCOS. However, these positive effects decline after 3 days, so consistency is key. Women with PCOS should strength train 2 to 3 times per week. Nutrition plays a direct role. A 2024 randomized controlled trial investigating the MIND diet, combining Mediterranean and DASH dietary principles, found that after 8 weeks, participants reported lower depression and anxiety levels alongside improved metabolic markers. Diet does not have to be perfect. It has to be anti-inflammatory, fiber-rich, and protein-forward. The Mediterranean approach, vegetables, legumes, whole grains, healthy fats, lean protein, is consistently the best evidenced dietary pattern for insulin resistance management in PCOS. Medication. The 2023 updated International PCOS Guideline recommends that metformin, in addition to lifestyle intervention, should be considered in adults with PCOS for prevention of weight gain and management of metabolic disorders. Metformin, the most widely prescribed insulin sensitizer, directly reduces hyperinsulinemia, lowers androgen levels downstream, and can restore menstrual regularity in a significant proportion of women. Combined oral contraceptives regulate cycles, reduce androgen-driven symptoms including acne and hirsutism, and protect the uterine lining in women with infrequent periods. For women pursuing fertility, letrozole is now the first-line ovulation induction agent, replacing clomiphene in most guidelines due to superior live birth rates. Emerging research on GLP-1 receptor agonists, including semaglutide, shows significant promise for weight management and insulin resistance reduction in PCOS, with ongoing trials defining optimal protocols. Mental health, non-negotiable. Cognitive behavioral therapy can help reduce depression and anxiety in women with PCOS. The psychological burden of PCOS is not secondary. It is a direct consequence of the hormonal and metabolic environment, and it deserves direct, consistent treatment alongside physical interventions. If you are managing PCOS physically but not addressing the mental health dimension, you are treating half the condition. Section 8. How to support someone with PCOS. If someone in your life has PCOS, here is what the evidence and the lived experience of millions of women says actually helps. Believe them when they describe their symptoms. PCOS symptoms are frequently minimized by clinicians, family members, and partners as cosmetic concerns or lifestyle failures. The most powerful thing you can offer is the opposite, unconditional belief that what they are experiencing is real, medical, and not their fault. Do not reduce it to weight. The relationship between PCOS and weight is medically complex and emotionally loaded. Have you tried losing weight? Is not support. It is a dismissal that most women with PCOS have already heard dozens of times. Ask instead, what do you need right now? What can I help with? Help them advocate in medical settings. PCOS is frequently underdiagnosed and undertreated. Help the person you care about prepare questions for appointments, request the right blood panels, including fasting insulin, free testosterone, and LH/FSH ratio, and push back if their concerns are dismissed. Show up consistently. PCOS is a lifelong condition with cycles of symptoms that can be unpredictable and exhausting. The greatest support is not a single gesture, it is sustained, patient, consistent presence. A message of hope. If you are watching this and recognizing yourself in these symptoms, in the irregular cycles, the unexplained weight, the acne, the hair, the fatigue, the mood that no one around you seems to understand, I want to say this to you directly. You are not imagining it. You are not lazy. You are not broken. You may be one of the 65 million women worldwide living with a condition that is real, named, researched, and manageable, and that has simply not been explained to you properly yet. The first step is the most important one. Ask your doctor to evaluate you for PCOS. Request fasting insulin, free and total testosterone, LH, FSH, and an ultrasound if appropriate. Bring this video if you need to. Your symptoms deserve a clinical answer, not a dismissal. PCOS does not have a cure, but it has a path forward. And you deserve to know what that path looks like. If this video gave you a name for something you've been feeling, or clarity on someone you love, like this video. It helps more women find this information before another decade passes without a diagnosis. Subscribe. We cover women's health, medical science, and evidence-based wellness every week at this depth. Comment below. Tell me, how long did it take you or someone you know to get a PCOS diagnosis? Your answer might be the thing that makes another woman in the comments realize she's not alone. Share this with the teenage girl in your life whose period isn't normal, with the friend who's been struggling to conceive, with the woman who's been told to just lose weight and never got an explanation why it's so hard. You might be the reason they finally get the answer they deserve. See you in the next one.